Hi students, hope you're all doing good. In this video, we are going to start one important topic in obstetrics and gynecology, that is hypertensive disorders in pregnancy. See, this is one of the important cause of maternal death. Okay, so the first direct cause of maternal death, if you take, it is hemorrhage. Okay, and hypertensive disorders are the second direct cause of maternal death. Clear? Yes. And if you see, in India, 7 to 8% of the pregnancies are complicated with hypertension or preeclampsia, right? And among this, around 5% of the maternal deaths occur due to hypertensive disorders. Clear? So, we'll see the definition of hypertensive disorders first. So, definition is when you record a BP more than or equal to 140/90, okay, then you have to do 2 readings, okay, 4 hours apart, okay. So, hypertensive disorders in pregnancy are diagnosed when you record a systolic BP more than or equal to 140 mm mercury or, okay, diastolic BP more than or equal to 90 mm mercury, or if you are able to see both the rise in systolic as well as diastolic BP. Clear? And also, this reading should be repeated, okay. You have to re-record this BP at a gap of 4 hours, okay. So, if both the values are elevated, then you have to suspect hypertensive disorders in pregnancy, right. And also remember, this 4 hours is not applicable when you record a BP of more than 160 and 110 mm mercury at the first recording itself, okay. So, that means you have to record it immediately within 15 to 30 minutes itself. You have to repeat the BP. This is because we have to give the patient the necessary treatment as soon as possible, right. See, the gold standard for measuring BP is by sphygmomanometer, okay. Ideally, the cuff size should be 2/3 of the arm circumference area. In other words, 40% of the arm circumference area. Okay. So, before asking the patient for recording a BP, see that the patient is in rest for at least 5 to 10 minutes. Okay. There was no smoking or ingestion of tea or caffeine at least 30 minutes before recording the BP, okay, and her bladder and bowel should also be comfortable. Clear? So, these conditions you have to see first. Then you can record the BP in a sitting position. While sitting, ask the patient to sit with the foot on her ground, okay, no crossing of the foot should be there. And she should sit comfortably, okay. Suppose if this is not comfortable for the patient, you can ask her to lie in the left lateral position. Clear? While measuring, you have to inflate the bladder of the sphygmomanometer's cuff, okay. While measuring BP, the bladder cuff of the sphygmomanometer should be elevated at least 30 mm mercury above the point of radial pulse extinction, okay. And remember, while bringing down, that is while deflating, you have to do it at a speed of 2 mm mercury per beat, right. And you will record your systolic BP when you hear a first clear tapping sound. Okay, so that is nothing but Korotokov sound phase 1. Okay, and you will record your diastolic BP when there is disappearance of the tapping sounds. Okay, so this is Korotokov sound phase 5. Clear? Yes. See, nowadays we are even using automated BP apparatus. Okay, but it is a mercury sphygmomanometer which is gold standard one to measure BP. Okay, and remember, this screening for hypertensive disorders by recording BP should be done to all pregnant women, okay, at all her visits. Okay, clear? Now we will see the ACOG classification of hypertensive disorders in pregnancy. So, ACOG classification. We have 4 categories of hypertensive disorders in pregnancy. First one is gestational hypertension. Second one is preeclampsia. Third category is preeclampsia superimposed on chronic hypertension. And fourth one is chronic hypertension itself. Okay. Clear? So, these are the 4 categories. Again, will come up again. It is gestational hypertension, preeclampsia superimposed on chronic hypertension, and then chronic hypertension. Clear? Yes. We will see gestational hypertension. See here, as we have seen, the systolic BP can be equal to 140 millimeter mercury, or the diastolic BP is more than 90 millimeter, or both are seen, and this recording of BP should be done anytime about 20 weeks of gestational age. Okay, and remember, importantly, it is not associated with proteinuria, okay, or signs of end organ damage. Okay, so these two are absent. Okay, so if you take gestational hypertension, it can progress into preeclampsia. Okay, so it can progress into preeclampsia when it is associated with, yes, proteinuria and end organ damage. Okay, and it can become a chronic hypertension also. Okay, you can diagnose it as chronic hypertension when it persists beyond 12 weeks after delivery. Okay, so it persists after 12 weeks of delivery. Okay, sometimes this can be a transient hypertension also. Okay, that is within 12 weeks of after delivery, the values become normal. Clear? See, if you take gestational hypertension, if it is seen before 34 weeks of pregnancy, the risk is high. Okay, because the prognosis to preeclampsia chance is more. Okay, so it will be around 25 to 50% chance. Okay, whereas if it is seen more than 34 weeks, then the risk of conversion of gestational hypertension to preeclampsia is less, and usually the prognosis is good. Clear? Next we will see preeclampsia. So preeclampsia, the incidence of preeclampsia is around 13 to 37%, and remember this will be mostly a new onset hypertension. And when it will occur? Yes, after 20 weeks of gestational age. And what is the other criteria? Other than increase in BP, what you should have? You should have proteinuria or end organ damage. Okay. Now, we will see when we can call it as a proteinuria. Okay. So, proteinuria is defined when you are able to see more than or equal to 300 milligram of protein in a 24-hour urine sample, or your spot urine protein creatine ratio is more than or equal to 0.3, and your random sample of urine contains protein around 30 milligram per deciliter, and then your urine dipstick shows more than or equal to 1 plus, but according to ACOG, this is considered as more than or equal to 2 plus, okay, but we can keep more than 1 plus itself, we have to suspect preeclampsia, okay. So, in other words, whenever a patient is presenting to you with a BP more than 140/90, okay, then the next step is what? We have to check for proteinuria. So, the next step is you are going to check for proteinuria, okay. And among this, which method you will choose? Which is the least and among the said methods, which method you will choose? You will choose dipstick method, okay. So, that is very easy to do, okay. So, what you will do is, if there is more than or equal to 1 plus, okay, then you can go for a 24-hour urine protein sample, or you can go for urine protein creatine ratio, okay. And among this, the gold standard is measurement of protein in a 24-hour urine sample. Clear? And suppose if it is coming traces, okay, or there is no protein in dipstick, means what you have to do is, you have to check whether any signs of end organ damage are present or not, okay. So, end organ damage signs you have to check, okay. Suppose if any of the end organ damage is present, then you have to assume that it is a case of preeclampsia. Suppose no end organ damage, means then you can be sure that it is not a case of preeclampsia. Clear? See, the definition of preeclampsia is, once again I will make it clear, it is either proteinuria or end organ damage. Clear? So, either of the things with increased BP, then you have to assume that it is a case of preeclampsia. Clear? Yes. Now, we will talk about end organ damage. End organ damage can present as reduced platelet count, that is less than 1 lakh of platelet count will be present, and it happens because of the microangiopathic hemolysis, okay, and also there is platelet activation and aggregation. Clear? Next parameter we have to check is about the liver. In the liver, there can be hepatocellular ischemia that will result in hepatocellular necrosis and hepatic edema also. Okay. So, due to this what happens is the serum transaminases rises above the normal range. Okay. But remember, this rises double the times of the normal range. Clear? Next one is kidneys. Kidneys also will have a impaired function, and if you see, the serum creatinine levels will be more than 1.1 milligram per deciliter, or there is doubling of the baseline values. Okay. Next is cerebral symptoms. Okay. There can be headache, okay, which does not settle with analgesics. And then convulsions can also occur. Remember, the other causes of convulsions has to be ruled out, and most importantly, you will be able to see visual disturbances due to change in the optic fundus, and sometimes pulmonary edema can also be seen. Clear? So, these are the signs of end organ damage in preeclampsia. So, if we take preeclampsia, this can be further divided into two types. Okay, so it can be a non-severe preeclampsia or severe preeclampsia. Okay, so the definition is again simple. So, the BP is more than 140/90 here, but it is going to be less than 160/110. Here the BP is going to be more than 160/110. Okay, and this can progress to severe preeclampsia also. Okay, but severe preeclampsia states that it is already a case of impending eclampsia. Okay, if the signs are present. Okay, if the warning signs are present. Okay, so warning signs include headache, vomiting, blurring of vision, then epigastric pain, and also oliguria. Okay, just about the end organ signs what we have discussed now. Okay, and similarly remember, and similarly clinical classification of preeclampsia can also be done. Okay, so if you take clinical classification of preeclampsia, this can be either early onset preeclampsia, that is happening less than 34 weeks, and next one is late onset preeclampsia, that is happening more than 34 weeks. Clear? We will see the difference now. See, early onset preeclampsia is mostly a placental syndrome. Okay, that will be affecting the fetus mainly. Okay, so here late onset preeclampsia will be mostly a kind of maternal syndrome due to underlying maternal constitutional factors. Okay, due to underlying maternal constitutional factors. Okay. So, what happens in placental syndrome or the early onset preeclampsia is there is reduction in the size of placenta. Okay. Here there is normal size of placenta or increased size of placenta. Okay. And here there is fetal growth restriction or low birth weight of the baby, whereas here the baby is of the normal birth weight and normal growth. Okay. No fetal growth restriction is seen. Okay. And similarly, if you do Doppler, okay, in this, that is the placental syndrome, you will be able to find abnormal uterine artery as well as umbilical artery Doppler. Okay. But here you will be able to see normal uterine and umbilical artery Doppler. Okay. And in the early onset preeclampsia, you may have adverse fetal and maternal outcomes. Okay. But here late onset preeclampsia, you have more favorable maternal and fetal outcomes. Clear? Here I want to add one more point, HELP syndrome, okay, which is hemolysis, elevated liver enzymes and low platelets. Okay. So, HELP syndrome can be a form of severe preeclampsia. Clear? Now, we will see eclampsia. See, eclampsia is a condition where a new onset, okay, generalized tonic-clonic seizures can occur in a women with the preeclampsia. Okay. And this mostly occurs in the second half of the pregnancy. And it can occur up to 48 hours postpartum. Okay. Mostly rare after that. Okay. But up to 48 hours you should be careful. And next one is about chronic hypertension. See, this can be diagnosed in two ways. Either it will be seen before 20 weeks of gestational age or it progresses after 12 weeks of delivery. Okay. Suppose if it is becoming normal after 12 weeks of delivery, then it is called as, yes, transient hypertension. Okay. Next we will see what is this preeclampsia superimposed on chronic hypertension. So, preeclampsia superimposed on chronic hypertension. Here you will have worsening of the symptoms and a new onset proteinuria or already if she is a known case of chronic hypertension and had proteinuria, the severity of the proteinuria will at least change. Okay. So, this is the definition for preeclampsia superimposed on chronic hypertension. Okay. And any other end organ damage signs can also be present. Clear? Yes. Okay. Now, we will start discussing in detail about preeclampsia. So, first we will see what are the risk factors. So, the risk factors include number 1, primigravida, okay, and extremes of age, okay. So, extremes of age like age less than 18 or age more than 40. Also, the risk is more when there is a high BMI more than 30 kilogram per meter square, okay, or she is a known case of diabetes mellitus or hypertension already, and she has kidney disorders, or she is a known case of connective tissue disorders like SLE. Then there was a history of Apla syndrome or thrombophilias. Then she had a previous history of preeclampsia and family history of preeclampsia in the mother or the sister. Then in pregnancies due to IVF. Then when there is a longer interpregnancy interval, okay, that is more than 10 years, okay, and in the baby there is fetal hydrops or it is a molar pregnancy, vesicular mole is present, then it is a multiple pregnancy, then there can also be environmental factors that will be playing a role. Clear? So, I hope you got it. Now, we will see the pathophysiology, why all these are considered as risk factors. Okay, if you see the pathophysiology, then you will be able to make out the risk factors very easily. Okay, so pathophysiology. Gestational hypertension or preeclampsia is more likely to develop in women who are having their first exposure to villi. Okay, so if you take, so they are exposed to the chorionic villi for the first time, or they are exposed to abundance of chorionic villi. Okay, means in where abundance of chorionic villi is seen, it is seen in multiple pregnancy or vesicular mole. And third one, any condition that is associated with endothelial cell activation and inflammation and also genetic factors. Okay, so any conditions associated with endothelial cell activation or inflammation and also genetic predisposition. Okay, so we'll see what are the mechanisms that these factors are going to cause preeclampsia. So mechanisms they cause preeclampsia. Okay, first one is abnormal trophoblastic invasion of the uterine vessels. Okay, so there is abnormal trophoblastic invasion of uterine vessels. then dysfunctional immunological tolerance. Okay. So, there is dysfunctional immunological tolerance between the maternal, fetal and placental tissues. Okay. That is maternal maladaptation to the physiological changes, especially in the CVS system. Okay. So, maternal maladaptation to CVS changes of normal pregnancy. Okay. Clear? So, these are the mechanisms. So, if we take preeclampsia, we can see it happening in two stages. Okay. The stage 1 is the placental syndrome. Okay. The placenta is going to show some changes first. Then it is going to affect the mother, which will be seen as some clinical features of preeclampsia. Clear? So, preeclampsia as such presents in two stages. Okay. So, what is the stage 1? It is the placental syndrome. Okay. Whereas stage 2 can be considered as a maternal syndrome. Clear? Okay. First we will see what is going to happen in normal pregnancy. Okay. So, in a case of normal pregnancy, if you take, there are maternal spiral arterioles. Okay. So, let us take, this is the maternal spiral arterioles, and these maternal spiral arterioles are going to be invaded by, yes, it is the extravillous trophoblast that is going to invade the maternal spiral arteries, and in extravillous trophoblast it is specifically endovascular trophoblast. Okay. So, this invasion is going to increase the diameter of the spiral arterioles. Okay. And this is called as vascular remodeling. Okay. Clear? Now, if you take the uterus, okay, so you have the endometrium layer, middle myometrium layer and outer perimetrium layer, right? And the spiral arterioles are going to come from the uterine arteries, and it is going to be like this, right? So, this invasion of the trophoblast, okay, so invasion of the trophoblast is happening in this direction, right? So, this invasion happens in two stages, okay, it happens in two stages, that is up to 12 weeks, it will be invading only the decidua, okay, decidua is the endometrium of pregnancy, okay. Then from 12 to 20 weeks, this will be invading up to the myometrium, okay. See, most of the times the invasion by the endovascular trophoblast up to decidua happens normally, okay. The problem is when it cannot invade the myometrium, okay. So, that is when the placental syndrome presents, okay. So, if we take preeclampsia, main point is the trophoblastic invasion is incomplete. Okay. So, what is happening? The decidual vessels are invaded by the trophoblasts, but not the myometrial vessels. Okay. Also, in this case, anti-angiogenic factors can also play a role. Okay. So, All these things will lead to decreased placental blood flow. Then it will lead to now all these factors will lead to reduced placental blood flow. Okay, that means the perfusion is also reduced. It will create a hypoxic environment. Clear? Now let's understand the process with this picture. So you are able to see a non-pregnant uterus. Normally this is the spiral artery that is going to supply the endometrium as well as the myometrium. Clear? Now what is going to happen in preeclampsia is there should be invasion of the endovascular trophoblast inside the spiral artery to make it more dilated, right? But this invasion is happening up to the endometrium only, and this is the myometrium where it is going to remain in the normal non-pregnant state itself. Okay, so this is going to bring increased resistance in the spiral arteries, and hence the vascular blood flow is also reduced. Clear? Now I want to make you clear that there is a state of placental ischemia, right? So this you have understood. So it will be resulting in reduced size of the placenta, as well as what is going to happen? Reduced blood flow to the fetus. So reduced blood flow to fetus. So the overall growth of the fetus is affected, that will be resulting in FGR, and there is reduced blood flow to the kidneys of the fetus also. So that will be leading to oliguria, and ultimately oliguria will be ending up as, yes, very good, it is oligohydramnios. Right? Next we will see some genetic factors. Okay. See, genes for anti-angiogenic factors for preeclampsia is located on chromosome 13. Okay. So, anti-angiogenic factors in preeclampsia is located on chromosome 13. Okay. And remember, the gene located and also remember there is increased protein expression. The protein is called as semaphorin 3 protein. Okay. So this protein expression is increased, that will be resulting in impaired trophoblastic differentiation and that will be resulting in impaired vasculogenesis. Clear? Now we will see what is happening in stage 2, that is maternal syndrome. In stage 2, there is gestational hypertension, preeclampsia, fetal growth restriction. There can be chances of preterm delivery. Then abruption can also happen. Okay. And also remember, there is endothelial cell dysfunction and inflammation happening. Okay. So there is also endothelial cell damage and dysfunction. Okay. That will be leading to inflammation. Okay. So during inflammation, inflammatory mediators like cytokines, TNF alpha are released. Okay. So, this will be leading to oxidative stress. Okay. Because of the increased production of oxygen free radicals. Okay. Now, this is going to cause injury to the endothelial cells. Okay. And remember, there is increased production of prostaglandin I2 and increased production of thromboxane A2, but there is reduced production of nitric oxide. Clear? And also remember, because of the endothelial cell injury, the permeability is going to increase. Okay. So, what is going to happen? There is fluid accumulation outside the vascular space, that is called as edema, as well as also this is going to cause proteinuria, right? So, endothelial cell damage will result in greater capillary permeability, right? So, that is going to result in edema, and when the glomerular capillaries are affected, it is going to result in proteinuria. Clear? Right. So, remember, these damaged endothelial cells are going to release a substance called endothelin, and already we know there is a reduction in nitric oxide and there is a increased levels of thromboxane A2. Okay. So, all these conditions are going to cause vasospasm in blood vessels, okay, and that is going to cause ischemia in the surrounding tissues, okay, that will result in necrosis and hemorrhage, okay. Clear? And also inside the vessels there is lipid laden macrophages, okay, seen where inside the placental vessels, okay. So, this is going to cause activation of the systemic microvascular coagulation system, okay. And what this is going to happen? With this, the features of DAC will develop and it will result in thrombocytopenia in the blood vessels. Clear? And remember, thrombocytopenia is the first hematological manifestation. Clear? So, remember, there is an imbalance between the angiogenic factors and anti-angiogenic factors also. Okay. So, if you take the angiogenic factors, they include vascular endothelial growth factor, placental growth factor, okay. So, these things are reduced. Whereas, if you take the anti-angiogenic factors, they include soluble FMS like tyrosine kinase, okay. And next one is soluble endoglan. What will happen to this? These are increased. Clear? So, remember this, okay. Finally, we are making this clear in this video itself, right. So, there is a normal pregnant mother, maternal spiral arterioles appears to be normal. Then, if there is normal cytotrophoblast invasion, then there is going to be normoxia, no resistance to the blood flow. So, there is increased blood flow, and also remember the pro-angiogenic factors are going to be on the higher side, namely the placental growth factor and vascular endothelial growth factor also, okay. And the soluble endocrine and soluble FMS like tyrosine kinase 1 are the anti-angiogenic factors which are going to be on the lower side, right? Whereas in preeclamptic pregnant mother, what is going to happen is there is abnormal spiral arterioles. Okay, so that is going to cause reduced trophoblastic invasion, and there is placental hypoxia that will be leading to placental ischemia and increased oxidative stress that will be reducing the blood flow. So it will be resulting in reduced levels of pro-angiogenic factors, and there is increased levels of anti-angiogenic factors. Okay, so that will be resulting in abnormal angiogenesis. Clear? Now I hope there is no doubt in the pathogenesis. Right. Okay. Now, I want to make clear about the pathological changes in different systems also. Okay. So, if we see the pathology in different systems, first going to be affected and the most commonly affected system is the renal system. Okay. So, what is going to happen here is there is glomerular capillary endotheliosis. So, that will be causing reduced blood flow. Okay, that will be resulting in oliguria. Okay, and also we have seen that there is endothelial cell damage, and it will be leading to glomerular capillary damage will be leading to, yes, very good, proteinuria. And remember, the serum creatinine levels increase, serum uric acid levels increase. Okay, so and also there is activation of the renin angiotensin aldosterone system that is going to cause sodium retention, and because of the ischemia there is going to be acute tubular and cortical necrosis. Clear? And the second important system is the hematological system. Okay, so if you see the hematological changes, there is microangiopathic. If you see the hematological changes, there is microangiopathic hemolysis. Okay, there is microangiopathic hemolysis. This occurs due to, one is endothelial damage, second one is platelet activation and adherence. Okay, and the third one is fibrin deposition in the vessel walls. Okay, and because of this hemolysis, you will be able to see increased levels of LDH, okay, in the serum, and because of the breakdown of the cells, you will be able to see cystocytes and also spherocytes where in the peripheral smear. Okay, then platelet adhesion and activation is going to lead to thrombocytopenia. Okay, and also there is intravascular coagulation system that is going to get activated, that will lead to increased levels of D-dimers. Okay, and there is reduced levels of factor 8, antithrombin 3, protein C and protein S. Okay, clear? Okay. And I want to tell you that thrombocytopenia is the first hematological change that will be occurring. Okay. Next is changes in the CNS system. Okay. So this is very significant and it may even cause convulsions. Okay. So significant to cause convulsions. Okay. There are cortical and subcortical hemorrhages. Cortical and subcortical hemorrhages are seen. So what is happening is, as we have seen, there is endothelial damage that will be leading to increased leakage of fluid, okay, and that will be resulting in perivascular edema, okay. Also, there is cerebral hyperperfusion. So these will be seen with this, these will be presenting. So these can present as headache, scotoma or papilledema. So cerebral symptoms can present as headache. Also symptoms in the eye, like there can be scotoma or papilledema, okay, and even hypertensive retinopathy changes, and there can be retinal detachment also, okay. And among this, remember, scotoma is the first visual change to occur, okay. So this is the first visual change to occur, okay. And you have to see that the occipital lobes can be affected and it can lead to diplopia, blurred vision or blindness, okay. So all these symptoms when together, when occurring together, so repeat. Also, when the occipital lobes are affected, they can present as diplopia, blurring of vision or even blindness sometimes, okay. So all these symptoms can happen together in a syndrome called posterior reversible encephalopathy syndrome, okay. So that is PRESS. Clear? Okay. Okay, with this we'll finish this video. Until we meet in the next video, take care, happy learning and bye bye.